Well, as you all trickle in, welcome. This is the Fed Principal webinar. We're honored to have you here and join us for a deep dive into fidelity, equity, and dignity in produce prescription programming. I'm Maham Rizvi. I work as a produce prescription specialist with DAISA Enterprises, and we're a national team of equity-focused consultants working at the intersection of food, culture, and health. And a few of us have actually formerly worked at the Nutrition Incentive Hub as technical assistants for GusNIP applicants. And so we're deeply committed to embedding an equity framework into our field of produce prescriptions. We're honored to have you all here with us, our peers, and look forward to sharing all aspects of the Fed Principal with you today. You'll be hearing from a breadth of folks who've contributed to the development of this work. We've been working together since spring 2021, and you'll get to hear from Yale School of Public Health, Prevention Research Center, Upstream, Hispanic Health Council in Hartford, Connecticut, Wholesome Wave teammates, another colleague of mine at DAISA, and a colleague of ours at the Tufts University Food is Medicine Institute. This work was made possible by the Walmart Foundation through walmart.org Center for Racial Equity, and we're definitely grateful. I want to share a little bit about who you all are in the room with us today, joining as audience members. We're so grateful you all registered, and from your registrations, we were able to get a sense of your role in the field of produce prescriptions and food as medicine work. And we came to find out that almost a quarter of you, there are just shy of 500 registrants today, almost a quarter of you operate a produce prescription program. And that's phenomenal to know you all are in the room. We're your colleagues. We've made this for you. It's made by many of you, and hope you can find it a fruitful takeaway. We also have plenty of researchers and folks who work in the healthcare arm of produce prescription programming. And many of you also shared that you don't necessarily work in this field, but perhaps something adjacent. We love that you're here as well, and we hope you find it useful and find connection with it. Some of what we'll be covering today, of course, an overview of what FED is and some of the qualitative research that went into informing us it's needed for the field. The FED Community Workbook in action within a produce prescription program in Hartford, Connecticut. You'll also get a chance to practice the workbook slightly. I'll guide you through that. You'll hear about what's in the FED pipeline and how it can be applied at the policy level, as well as FED's meaning for the wider food as medicine field. We'll also get a chance to talk through any questions you have, and we'll have a spacious 30-minute Q&A session, so don't feel shy about that. A little bit of housekeeping before we dive into presentations. If you haven't already, we'd love to know who you are in the chat. Utilize the chat to introduce yourself. Tell us your name, your pronouns, the organization you work with, and where you're calling in from. For any questions you start to come up with that should be directed to a speaker, please add them directly to your Q&A button at the bottom of your Zoom screen. We'll make sure to go through those at the end of our talk today. And the presentation materials, this webinar is being recorded, and the slides will be shared out with all registrants in a follow-up email after the presentations. I'm going to pass it on to our colleague, Benjamin Perkins. Ben, welcome and take it away.
Thanks, Maham, and good day, everyone. I am honored to be a part of this webinar and grateful to all who helped to make this day possible. Again, I'm Ben Perkins, and I am the Fed Director at Wholesome Wave and the CEO and founder of Upstream Impact Solutions Consulting. So my journey to creating the Fed Principal came out of my desire to develop an elegant, concise framework that constituted the core elements of an impactful intervention. And as a public health professional with over 20 years of experience, it became increasingly clear to me that without these elements, interventions were not likely to be successful, no matter how well-intentioned they were. and that profoundly structural inequities that we see embedded in almost every sector of civil society would continue not only to exist, but persist. And it was never lost on me that despite working in various public health conditions or issues as diverse as HIV/AIDS, cardiovascular disease, and of course, food and nutrition security, that the same populations were disproportionately impacted, namely BIPOC and poor communities. So this ultimately was kind of the fertile soil out of which the Fed principle was born as a way to grapple with the fears, the frustrations, the ambitions and aspirations that are all part of our journey to creating a healthier, more just society. Next slide, please. And so that brings us to the Fed principle itself. And so the components of the Fed principle are threefold. First, there is fidelity, that we do nothing for communities without them playing a central role in the design and implementation of the intervention. And then second, there is equity, that we work to ensure our efforts create access, in this case to healthy foods, and that we interrogate our policies and practices to ensure that we as an organization are in fact walking our talk. And then finally, dignity. And the idea here is that we as human beings have inherent worth, regardless of our social location. And as such, we are all entitled to health and well-being. And that, of course, includes access to healthy food. Now, one important thing to stress here is that the Fed principle is not a program, but rather an approach or a philosophy to creating programs, in this case, produce prescription programs, and beyond, I would say, because ultimately, I think Fed has broad applicability beyond just thinking about produce prescriptions. So next slide, please. And so all of this begs the question, what does a Fed principle-informed produce prescription program look like? And while we acknowledge that produce prescription programs all have core common elements, as indicated on the far left here, a couple of examples of those sort of core elements, core components of all produce prescription programs, the Fed principle itself offers or provides a framework to weave in deeper human-centered and equity-based considerations, both qualitatively and quantitatively. So with the help of our national advisory group, staff members, our co-design partners such as Yale and DAISA and Upstream, we developed a rubric to distinguish between what we call conventional programs and Fed-informed programs. And so in the interest of time, while I can't go over all of this particular chart, what I will say that it is found in our Fed workbook. And also what I'll do here is just highlight three particular examples to showcase each of the elements of the Fed principle, that is fidelity, equity, and dignity. So first, I want to call your attention to the first highlighted item in the column that says conventional non-Fed programs. And that is the highlighted item in blue. And you'll notice here that in a conventional program, the typical focus is on individual patients, pathologies, and the outcomes are focused on changes in patient biometrics like BMI. By contrast, if you look to your immediate right under the Fed produce prescription programs, here, Fed considerations look at the household, the family, community health. And there are additional outcomes that we're interested in, such as social cohesion, mental health, and evidence of power shifting. And we would then submit that that is an example of fidelity in a produce prescription program. So next, I want to call your attention to an example of equity. And so if you look again in the conventional non-Fed produce prescription to the last highlighted blue item, you'll see here that we talk about the idea of redemption options. And in this case, the idea here is that in a traditional program, no attention is typically paid to where the produce or where the prescription dollars go after the transaction. Whereas if we look at it from a Fed lens, we have a deep interest in prescription redemption, and the idea that it drives the development of a stronger food system. We want to pay attention to local farmers, to community asset building whenever and wherever possible. And so that we would submit is an example of equity in a produce prescription program. And then the last example I want to draw your attention to is the second item in the column, second blue item in the column, looking at patients. And this is all, again, this is an example of what we would say is dignity. In a traditional program, the framing is often that patients have a deficit in knowledge or decision making. And what we would submit in a Fed framework is that patients actually have assets of wisdom and culture and community. And again, we would submit that this is an example of what we would say is dignity. So broadly speaking here, with the Fed principle, we are seeking to engage communities in ways that increase agency and social cohesion, which can improve, of course, health outcomes, but I think even more importantly, move communities closer to an ideal of food sovereignty. And I think ultimately therein lies the promise and the potential of a Fed produce-informed produce prescription program. And we are really excited to collaborate with each of you on what we consider this journey, this labor of love and justice. And so again, thank you for being here. And I am excited to turn it over to my colleague, Elena Rodriguez, who's going to talk specifically about the Fed Community Workbook that I briefly talked about in the rubric comparing the Fed and non-Fed programs. So Elena, the floor is yours. Thanks.
Thank you, Ben. Welcome, everyone. I am so excited to be here. As Ben mentioned, my name is Elena Rodriguez. I am the Director of Research and Community Partnerships at DAISA Enterprises, colleague of Maham. And over the past now 3.5 years, we have been working in collaboration with Ben, with Wholesome Wave, with partners at Yale, to lead, to work on building out this Fed principle. But specifically, I have been delving into multiple research efforts, looking at the produce prescription field, and I'm really excited to present some of that work today. So I'm going to start by bringing you along some of the key developments in this research and learning trajectory that has really set the stage for today's launch of the Fed Community Workbook. And then I'm going to explain some key concepts in the workbook so that you all can get a feel for how to navigate it and use it. My first main takeaway to share with you all before jumping in is that the creation of the Fed Workbook and really the Fed principle as a whole, as Ben just described it, builds upon a groundswell of learning that has centered diverse perspectives and shows us just how needed this model is in the food as medicine field. So next slide, please. So yes, as I said, I'm going to jump into why was Fed developed. We can actually go over to the next slide. As a part of a 2021 Wholesome Wave national survey that we collaborated on with them, a survey of 800 produce prescription and nutrition incentive programs, we learned that 63% of survey respondents reported a need for resources that are aimed at better incorporating racial equity into program implementation. This felt really significant to us and really encouraged us to explore and delve into this topic further. Also in 2021, Wholesome Wave and DAISA collaborated to publish a field scan report documenting the growth of the produce prescription field over the last decade. This report was the first of its kind to document where programs were located in the country, understand the intricacies of how they function, and also to gather in-depth program operator experiences and challenges. So we then built upon that field scan in 2022 and 2023, by embarking on a participatory study exploring the experiences of Black, Indigenous, and other people of color, BIPOC, produce prescription operators. We set out to learn more about not only what challenges and barriers they experience in the field, but to also understand their unique innovations and successes. And on to the next slide. On the next slide, you can see listed here a summary of our main findings from this Produce Prescription BIPOC leadership research. So on the left-hand side, you can see the successes and strengths. We learned how BIPOC-led programs exhibited strong successes in areas such as community-directed programming, social and cultural connectedness, centering cultural foods, resource stewardship, and more, as you can see. And then on the right-hand side, we learned that they continue to struggle against systemic oppression, which limits access to funding, visibility in the field, equitable partnership development, and field opportunities in general. The findings pointed really strongly to the need for additional frameworks to shift power and to place BIPOC leaders and programs at the center of food as medicine work. The innovations that these BIPOC leaders shared with us, the innovations that they have nurtured in their own communities, demonstrate the real power of grassroots solutions developed by those facing the steepest challenges in community health and food security. So these findings and the specific anecdotes that surfaced in our interviews with BIPOC program operators across the country informed the development of the Fed Community Workbook as a whole and the development of the specific criteria, which we'll get into in just a minute. So again, what I want you all to take from this very brief overview of research trajectory is that the Fed principle as a concept and the workbook as a specific tool have simultaneously been built alongside these research efforts. And we've been able to see in real time how many BIPOC-led, BIPOC community-embedded organizations have been inherently operating in what we consider Fed-aligned way. So the creation of the Fed principle and these related tools is really an effort to help give language and to lift up BIPOC wisdom and experience. Next slide, please. So what is the Fed Community Workbook? How can it be used? I'm going to delve into the structure of the workbook itself and explain some of the key concepts and what we mean by them. Next slide, please. We know that produce prescription programs often necessitate a diverse set of partners or collaborators who are working together to bridge food and healthcare systems. This slide that you're seeing, the flow of a produce prescription program image, we created this as a part of our original field scan research, and it shows, again, kind of the movement through program operations. It starts on the upper right-hand corner with the patient or program participant going through an eligibility screening, receiving a referral to the program, most often by a healthcare partner. The patient is then provided with a prescription. They then redeem that prescription, usually in a retail setting, such as a farmer's market or a grocery store. And then some programs offer nutrition or culinary education as an additional support to increase program participation. And finally, most programs do collect data on outreach, participation, and program outcomes. So I want to mention that we know that produce prescription programming is very diverse and it is often adjusted to the unique realities of a particular community. And we know that some programs may not look exactly like this flow diagram. They may not have all of these steps listed, or they may utilize other innovative program delivery methods. But following this flow image, each interaction of these program partners creates what we called in the workbook a program touch point, which is a major function or process in program implementation. Next slide, please. So this slide shows a list of the produce prescription program touch points as we've defined them in the workbook. So you will see that the bulk of the workbook is organized by these 7 touch points. Each of these steps or interactions provides a really ample opportunity to delve into how programs can further embed equity into their operations. From the previous slide, from the list of the flow of produce prescription program, we've added an additional layer of detail by including touch points of program management and program funding and sustainability, because while those are less visible in public facing programming, They are crucial steps for program success and additional opportunities to consider equity. Perfect, next slide. Okay, so what do we mean by criteria in the workbook? When we were studying how programs operate under each of those program touchpoints from the previous slide, we were observing real-world examples of what Fed-aligned programs look like. We began listing out all of the possible examples. There were initially 86. And as we understood that those examples represented some of the many possibilities that exist to better align program operations with the Fed principle. These criteria were developed with the guidance of a national advisory group, the NAG, which is comprised of produce prescription practitioners, health equity leaders, racial justice thought partners, healthcare funders, policy advocates, and evaluation experts. So through discussion with the NAG, these 86 criteria were distilled, categorized, and consolidated based on that wide range of experiences in the food as medicine field. In the workbook, under each of those 7 program touchpoints, you'll see a list of criteria. These criteria are then grouped by which of the 3 core values that they most close of the Fed principle that they most closely align with: fidelity, equity, and dignity. And then to aid in navigating and contextualizing the criteria, we've tagged them using a set of themes. So you can easily flip through the workbook, find a theme that you're interested in delving more into, or if you're more focused on fidelity, those are the ways you can kind of dig into the criteria. And I want to state that the criteria outlined in the workbook were created to be aspirational. There's no expectation that all of them will apply to every program or even be possible within every community. Instead, we really hope that they create the opportunity for program operators and their partners to have the necessary conversations and to explore together what possibilities exist. We also really encourage programs to create their own criteria that fit their community. You can see there's a little spot at the bottom where folks are encouraged to directly write in, and also to engage with us in editing and expanding the criteria in future workbook iterations. So it's definitely not set in stone, and I think we're viewing this as a living document that should grow and change over time. And that's just been, again, a little overview of some of the key pieces of the workbook, and I really appreciate everyone's attention, and I'm going to pass it over to Andrea, who is going to show us a real example of how their program uses the workbook.
All righty, thank you, Maria Elena. Hello, everyone. My name is Andrea Tristan Urrutia, and I am the Research Associate here at the Hispanic Health Council in Hartford, Connecticut. We are a nonprofit organization, and for this part of the presentation, I will be showing you the FET workbook in action, program design and implementation. So in the next slide, you can see the title of the program. So the program that I will be presenting is called Food for Moms, and it is both a feasibility study and a produce prescription program for pregnant Latina women. This is because we're not only implementing programmatic activities, but we're also simultaneously gathering data and evaluating outcomes. So in the next slide, you can see our funding source, which is the USDA, specifically the Gus Schumacher Nutrition Incentive Program and Point32 Health Foundation. Now, in this next slide, you can see that all the program implementers and implementation partners, so basically all of us since the beginning of 2023, the Hispanic Health Council, Wholesome Wave, and the Yale School of Public Health have been collaborating on creating Food for Moms in accordance with the FED principle. Now, in this next slide, I wanted to provide a brief summary of what the program entails. So one of our main objectives in Food for Moms is to enroll a total of 150 women who come from low-income backgrounds and who identify as Latina and are in their first or second trimester of pregnancy. This enrollment process is organized into 3 groups, consisting of 1 pilot group and 2 separate cohorts. Besides that, in terms of study deliverables, moms will receive $100 per month for 10 months for fresh produce. They will also receive nutrition education sessions, as well as text messages with reminders, nutrition tips, and recipes. Now, for the last deliverable, we have surveys. They will be asked to complete a baseline, a 3-month mark, and an end-line survey. So now in the next slide, we jump into the FET community workbook. You have now seen a brief summary of what Food for Moms is, and now we're going to jump into the program design and implementation using the workbook. So the planning for most of these program touch points that Maria Elena previously mentioned was completed before Food for Moms received the Fed Community Workbook. So moreover, at least half of these program touchpoints had already been implemented for the pilot group. This is why for us, the utilization of the Fed Community Workbook was done retrospectively. All right, so now moving on to the next slide. So with this slide, we can see the first program touchpoint along with its criteria. Before I go into detail, it is important to know that the workbook, like Elena said, has examples or criteria listed out of how we can exemplify the Fed principle for each program touchpoint. Now, the main exercise within the Fed Community Workbook is to sort of code the criteria based on its relationship to one's program, in my case with Food for Moms. So if you look at the orange box, you will see the different prompts. Prompt number 1 asks whether a criterion has been implemented. And if so, you can code it with an asterisk. The second prompt asks whether a criterion is not relevant or feasible. And if so, then you code it with an X. Lastly, the third prompt asks whether a criterion is something you have not tried, but are interested in doing so. And if so, you can code it with an exclamation point. So I, as the representative of the Food for Moms team, took the workbook and coded each criteria. So the first criterion I'll show you is one that I coded as implemented. You can see it highlighted in yellow, and I'll read the first sentence for you. So participant-centric community trust. Outreach strategy should be informed by communities rather than solely identified by statistical information on demographics and access. So for Food for Moms, we implemented this by conducting 3 listening sessions during what we call the co-design phase, where we asked members of the community, specifically women who were either pregnant or had children, for their thoughts and insights into all the components that were going to make up Food for Moms, including what locations they considered best for outreach and recruitment purposes. Now, in the next slide, I wanted to bring your attention onto this following criterion under the nutrition culinary education touchpoint. And it's highlighted in yellow, and I'll read it for you. So it's engagement. Activities are fun and celebratory, keeping participants engaged and maintaining pride in participation and progress, building a sense of community. So what Food for Moms did when creating their curriculum for the first nutrition education session was to make sure to include an icebreaker. Specifically, we were going to ask participants what were their traditional plates, the plates that they like cooking, including plates from their native countries. This was going to be the fun part of the session. However, once we actually conducted the session, we realized we did not have enough time, and people still did not feel comfortable enough to share. And we noticed this because since they were hardly anyone responded. So when I was going through this criterion, I thought, well, we did try to implement this, but there was definitely more we could do, more ways in which we could innovate, which is why I coded it as half. So when going back to nutritionists who helped build the curriculum and relaying this information, we all agreed that it would be best to reduce the amount of content per class, to leave more room for discussion and interaction in the form of games and activities such as guess the recipe, basically creating a more people-centered learning environment and enhance skill building within the class itself. Now, for the next slide, I have one criterion that I coded as not relevant or not feasible. This criterion is under the data collection and evaluation touchpoint and the equity principle, and it's called it's accessibility and transparency, and I'll read it for you, the first sentence. So participants can own and access their data and track their own progress towards goals. So for Food for Moms, we do not assign any specific health metrics or goals to participants other than our hope that they will use the entirety of their incentive to increase their access and consumption of fruits and vegetables. So right now, the way that Food for Moms is structured, this would not be relevant, which is why it's coded with an X. Now, for the next slide, this one shows a criterion that I coded as not implemented, but innovative. And you can see it highlighted in yellow under the program management touchpoint and the Fidelity principle. And I'll read it for you. So engagement, consistent proactive support and communication acknowledges that BIPOC patients face numerous obstacles to consistent program participation and access to healthy foods. Programs can help address disparities through frequent follow-up. So for Food for Moms, there's a lot of engagement happening towards the beginning of the study and when scheduling nutrition education sessions. But then the study after the beginning, it sort of slows down. And the only communication they receive from us are weekly text messages that include reminders, nutrition tips, or recipes. So after reading this criterion, discussion started among the Food for Moms team, starting to see how we can implement more frequent follow-ups. And right now we are considering incorporating monthly calls to ask our participants, how's it going? How's it going with their cards or boxes? What they might not be why they might not be using their cards or using the contents within the box, and so forth. So this wraps up the 4 criteria that I wanted to show you utilizing the different prompts within the workbook. Now for my next slide, and my last slide, I wanted to show you snippets of the digital workbook I made. I basically gathered all the criteria from the workbook into a Word document. This way I could easily jot down my thoughts on how we've tackled each criterion. Plus, it was a handy way to share and get feedback from other Food for Moms team members. So to wrap up my presentation, you've seen a snapshot of the workbook along with its program touchpoints and criteria. You've learned about the main exercise when using the workbook, which is to code whether you have implemented the criterion, whether it is not relevant or feasible, or whether it is something you have not yet thought about and would like to try it out. Thank you so much, and I'll pass it on to Maham.
Thank you so much, Andrea, for walking us through how you use the Fed Community Workbook. Now, you all in the audience, we're going to try and do the same thing here in Zoom. I'm going to do a practice session as if you had the workbook in your own hands, and I'm going to guide you through it. So we're going to start with reading one Fed criteria. This is found in the participant and recruitment and eligibility screening touchpoint and listed under an example, a way to exemplify dignity within your screening. And I'll just read it aloud for you all. Healthy food is a human right. To identify and enroll participants, more expansive criteria, such as food insecurity, can and should be considered as primary criteria, not only disease diagnosis. This is in essence if you're enrolling folks into your produce prescription programming. We're going to now launch a poll that's going to ask you if you would consider this something you've implemented in your program, something that's not relevant for your program or not feasible, or something that you don't yet implement but aspire to do so. So I'll set a timer. We have just a minute and a half. If folks could just respond to the poll that pops up, and then we'll share back results with you all. And I'll give folks a 30-second warning. Feel free to read it a time or two if you need to. And if any questions are coming up for you now, feel free to drop them in the Q&A. You've got about 30 seconds left. Okay, we're going to close out the poll now and share results with you all. All right. Thank you, Connor. Connor is on our back end helping launch and facilitate this poll. Wonderful to see. 55% of you say you probably already implement this. That's wonderful to know. Some folks don't necessarily do so, but hope to do so in the future. And only a few of you have told us it's not necessarily relevant or wouldn't necessarily work for your program. It's very helpful. Thank you, everyone. Close those results, and we're going to do one more. Same idea, going to read this criteria listed here. It's drawn from the data collection and evaluation touch point within the workbook and references an example of equity in a Fed-aligned produce prescription program. Participants can own and access their data and track their own progress towards goals. Data will make possible patient and community learning, in addition to the benefit of health systems, academics, and technology companies working to scale produce prescription programs and interventions. Community report backs of program impact should be incorporated as key milestones in program management. So we'll launch the poll again, and same thing, we'll have 2 minutes. All of y'all feel free to reread what's on the shared screen slide right now and give yourselves a chance to answer if this is something you already implement in your program, if it's something not relevant for your program, or something you aspire to implement in the future. Last 30 seconds here. All right, going to close out this poll and share back the answers. Nice, okay. This is wonderful. So fewer of you shared with us that you already implement this particular Fed exemplified criteria. But many of you, 77% of you who answered, said you're drawn to implementing it in the future. That's phenomenal. And a few folks shared that it's not necessarily relevant. Thank you all for giving this test run over Zoom of the Fed Community Workbook. We appreciate you bearing with us. And I hope that gave you a taste of how to utilize it once you've downloaded a copy for yourself. I'll pass it on to colleagues, Kathleen and Elizabeth.
Hello, everyone. I'm Kathleen O'Connor Duffany. I'm the co-director of the Yale-Griffin Prevention Research Center at the Yale School of Public Health. And I'm here with my colleague on the implementation evaluation team.
Hi, everyone. I'm delighted to be here with you all today. I'm Elizabeth Rhodes. I'm an implementation scientist based at Emory's Rollins School of Public Health and the Emory Global Diabetes Research Center. And I collaborate closely with Yale and the rest of the team that you've heard from today.
So we heard earlier from Ben on the Fed principle and the distinct ways Fed-aligned programs are different from non-Fed aligned programs. And Mary Elena and Andrea shared ways in which the community workbook can be used by programs to become Fed aligned. Now, what we're going to do is give you just a little sneak peek at some companion tools that are currently in development, or at least on the conceptual pipeline for development, for actual implementation and evaluation of these Fed-aligned programs. Now, if you take anything away from today, I would like it to be this. It is not just important that we do PRX programs, but critically important how we do PRX programs. Slide.
To ground our discussion about resources and tools today, we wanted to start with the Fed Action Framework. We created the Fed Action Framework to help guide our efforts to move the Fed principle into action. As you can see, this framework highlights that we have an opportunity to make produce prescription programs, as well as the systems in which they operate, more Fed-aligned. To create Fed-aligned programs, we can think about applying the Fed principle throughout the design, implementation, and evaluation phases of programs. To achieve fidelity, for example, we can co-design programs with communities, like Andrea described earlier during today's webinar. We can listen closely to community members as experts on their own experiences, and then use their insights and input to guide the design of our programs so that we can better meet their needs and preferences. We can also implement programs that are equitable and respectful so that all participants benefit and all participants feel they're being treated with respect and dignity while they are participating in produce prescription programs. Now, when we evaluate programs, we can expand the metrics that we use. In addition to our common measures to evaluate the impact of programs on health and healthcare use, for example, we can also integrate measures for equity and dignity into our evaluations. So we can aim to answer questions like, are all participants benefiting equally? Or are there some participants who are not benefiting as much as others, and why? We can also answer questions like, to what extent do participants feel they're being treated with respect and dignity by the people delivering the program? We can then use these evaluation results to identify areas where we can better promote fidelity, equity, and dignity in our programs, and then co-design improvements with community and implement and evaluate our programs through a continuous cycle, becoming more and more Fed-aligned over time. The new resources that we're excited to share with you today are intended to be useful for programs as they move through this co-design, implementation, and evaluation process. So I'm now going to pass it to Kathleen, who will share some of these new resources.
So some tools that we're currently working on for fidelity, equity, and dignity. Related to fidelity, we're working on a co-design manual. This is being led by our teammate, Rafael Perez Escamilla, along with and in partnership with the Hispanic Health Council Food for Moms program that Andrea shared with you earlier. Example as what this co-design manual may include, it includes such things as protocols for listening sessions. So for conducting listening sessions on the ground, what are we using for guides and protocols for those listening sessions? What questions are we asking? What questions are working? And not just within one site, but I'll show you also in other sites, we are adapting those and really keeping track of what works where and for whom. Also within the co-design manual, we'll be exploring the program impact pathway and really giving you a case study on how to use the program impact pathway as a tool to do consistent and rapid quality improvement of your programs for consistent community feedback and co-design throughout the life cycle of the program. Also, we're working on an equity manual. An example of some content of this would be really thinking to assess equity throughout the program. So how are we assessing it at recruitment, at redemption, through utilization, satisfaction, as well as equity in experience and in outcomes? Related to dignity, we've been working for about 2 years now, developing a scale to measure respectful PRX programming. This scale will then be able to be used within a survey as a module within a survey to assess respectful PRX programming. Slide. And we're doing this all within what we call the Fed Action Lab for implementation and evaluation. So we're developing these tools with PRX programs who are on the ground, actually delivering PRX programming. And we are using the tools, we're adapting the tools, and doing it with a diverse group. So if you look at right now, we're actually expanding from 5 to shortly in the next few months to 6 as we engage with the REACH program. The 5 that we're working with right now within our action lab have PRXs that are located and based in federally qualified health centers. So the FQHCs listed here, they're based at hospitals, and they're also based within CBOs. We're working with people who identify as food insecure, with prediabetes, with diabetes, and also with pregnant women. So we're getting this constant feedback to really adapt and change and improve our manuals as we're using them on the ground. Slide.
As we're developing tools for program implementers and running the action lab, we are simultaneously building the evidence base around FED programs by conducting research with our community clinical partners and publishing scientific articles. So just to give you a snapshot of this work, we're currently developing a case study on the co-design process for Food for Moms, the program that Andrea described earlier. We also have several articles in the works that will present our findings from recent evaluations of programs in California, including an evaluation that assessed equity in reach, uptake, and health outcomes among participants, as well as a qualitative evaluation of participants' experiences within programs, including the extent to which they felt they were treated with respect and dignity. We're also looking to evaluate promising strategies like the Action Lab that can optimize program implementation and ultimately allow us to realize the full benefits of produce prescription programs. So these are a few examples of our work. We also see many opportunities for individual programs and for the broader field to incorporate a focus on fidelity, equity, and dignity in their research and evaluations.
So here we just quickly discussed and shared 3 areas of our work and future work. So the tools that we are developing to support implementation and evaluation of a FED-aligned program, our FED Action Lab, which we are looking to expand for developing, sharing, and adapting the resources as we develop them. And then also our research and publications to support the evidence base of this work to inform practice and policy. So now I'd like to introduce you to Brent, who will discuss this informing policy piece. Brent?
Thanks so much, Kathleen and Elizabeth too, and hello everybody. Thank you all for being here. I hope these learnings have been helpful in your journey to advance equity in public health. I certainly know I've picked up some great new concepts and received a lot of good feedback here in the chat. So I want to also extend gratitude to the FED team, to the whole FED team, for the chance to collaborate on policy advocacy over the past few years now, and for inviting me to share some of my own thoughts and perspectives about the overlap of FED and policy as we stand here at the beginning of 2024. So I'm Brent Ling, I'm Director of External Affairs at Wholesome Wave. And in that role, I have the great privilege of overseeing our policy engagement and advocacy. Included in that work is serving as the Program Director for the National Produce Prescription Collaborative, but also we work on the Gushing Market Nutrition Incentive Program, the Farmers Market Nutrition Program, Healthy Food Procurement, and the Fruit and Vegetable Benefit and WIC Program. So I'll synthesize my message today to everyone in 2 real key points that I've observed and really believe wholeheartedly. One is that the window of opportunity for policy changes that will advance equity and reduce disparities nationwide, we call them windows of opportunity because they do close. So let us make sure to make the most progress we can while this window is open. And also let us make sure that we do work to make sure that the window stays open as long as possible. And my second take home is that policymaking is never perfect, and it often follows society more than society following policymaking. So some see the chaos and injustice in the policymaking process as reasons to step back and disengage, but Wholesome Wave's journey in policy advocacy really screams the opposite. Engaging is our compass to a better future. We must embrace the messiness, challenge the unfairness, and improve policy together. Next slide, please. So to start, I thought it important to highlight the major, really unprecedented policy changes that have happened in recent years, which have and will inevitably continue to drive a market and interest for the FED principles in all programming, but especially in food as medicine. So the work really began on day 1 with his first executive order in his really the first hours on the job, when President Biden executed an order on advancing racial equity and support for underserved communities throughout the federal government. Now, executive orders get a lot of flack for having bold and ambitious titles, setting expectations that this piece of paper is going to solve everything. So let us all lower or even rid ourselves of this application. If we've learned anything from any kind of study of injustice, we know it won't be resolved with the document. However, what this executive order did do is essentially say to all federal agencies, this is how we want to do things. This is what I want you to succeed on. If you want points with me, this is what I'm looking for. And we really saw the agencies respond in all areas of government, really. But here I'm just going to highlight some of the policy shifts in this executive order sparked in its wake related to food as medicine and the concepts we're talking about today. So just 100 days into the job, the Secretary of Agriculture announced major investments into the GusNIP and Produce Prescription Program, as well as the Farmers Market Nutrition Program. The USDA also launched its first ever Office of Nutrition Security and convened and held Equity Commission, which recently wrapped up over 2 years of work with a series of official policy recommendations. We've also seen investments in produce prescriptions from Veterans Health Administration, Indian Health Service, the Centers for Disease Control, and all of these food as medicine interventions are designed to reduce disparities in fruit and vegetable consumption and ultimately in diet-related disease. And at CMS, they have taken equity as seriously as ever, granting states flexibility to address health-related social needs through the Medicaid program, establishing health equity index and paying Medicare plans for success in reducing health disparities in a tangible way, and recently announcing population-level investments through a new all-payer model program ran out of CMMI, wherein grantees will be highly incentivized to provide more and more effective healthcare and public health services to those who would benefit most from access. There are many other policy changes from military through grant making and public access to information, additional legal protections, and that all of these I've seen advance through various areas of government as a result of the President Biden's first executive order on equity. But the reason I drive into so much into these is not to glorify a politician per se. It is to point out just how often the federal government is putting real money behind interventions that are demonstrated effective at advancing equity. So whether it be agriculture, public health, or health systems as a whole, there's real hunger to scale interventions which prove to drive health equity metrics. And the Fed models and learnings presented today can apply to all of it. Next slide, please. So now that we've reviewed some recent announcements, I'd like to share our perspective on the overlap of Fed and the policymaking process, commonly referred to as the sausage making. So in my personal experience, there's academic theory about how policy is made, and this is I attempted to illustrate this at the top here, top right. When the policy problem and politics streams align, that is when policy shifts tend to happen. And you can really make the case that this is how the policies I mentioned in the previous slide really developed. But then there's the perception that it's a handful of cliquey old white men in a cigar-filled back room with no public access and exposure or public input, and that they're really the ones who write policy. And similarly, you can see a lot of threads of truth in this perception in the previously mentioned policy changes as well. So the reality is that policymaking is almost always a combination of both. So let's look at a couple of examples which are both outside of food as medicine, but they are also useful. The first, the No Surprises Act, was really a result of years and years of people receiving immensely burdensome surprise medical bills, which drove hundreds of thousands of people into bankruptcy and caused immeasurable negative public impact on public health. For years, publications and podcasts and other news outlets would feature these stories. And one by one, these stories brought more and more policymakers to the table. In this case, the problem and the politics streams were robustly filled and flowing. However, when it came to the policy, the nuance of what causes surprise billing is incredibly complicated, and policy to address it is filled with unintended consequences at every turn. So ultimately, the No Surprises Act was written in close partnership with industry involvement. And 3 years later, the jury is still out on its efficacy in addressing the issue. There are plenty of advocates who hope this particular policy gets more teeth. Let's also look at the online SNAP or EBT. Back in 2013, the Farm Bill authors were not really hearing a lot of major public outcry to integrate SNAP for online shopping. Everybody knew it was on the horizon, but online grocery at the US was still very much in its infancy. And the complications around the EBT policy, the system and the policy that governed it, resulted in extremely murky path forward. Nevertheless, members of Congress knew it was important, and per the kind of bottom image of the cigar smoked back room, several members quietly and without a ton of public input directed the USDA to make SNAP function online for online grocery, but with very little direction and certainly no resources. So 6 years later, there was really still there was no or very little measurable progress. And SNAP Online was still very much a dream at that point. And then came the stay-at-home orders from COVID, and within the political will to really do whatever it took to make SNAP work online. So again, neither is perfect policy, and both were created with a bit of both policymaking process stereotypes described here. And the point I'd really like to make and drive home is that there is a role for science around fidelity, equity, and dignity in all the advocacy we do to advance public health. But the reality is that policymaking is part science, part behind the scenes power, and a good chunk of luck. Next slide, please. So this leads me to my call to action, and it is this. We are self-governing people, and everybody has a role to play in the policymaking process. The more active participation we have as advocates in sharing our learnings and experiences with policymakers, the more the resulting policy will work for people. The less we engage, the slower and more toothless policy can be. So the more policies that are made, and then the more policies will be made in the backroom power broking that we've mentioned, the more our national systems will continue to drive disparities and undignified experiences. So I have some tips here. But the reality is they all really take time and resources. They take the blood, sweat, tears, and time, and for nonprofits, that means money. So my encouragement to everybody is to make time for this work wherever you can. Today, it might be simply to email somebody a study that you read that you found interesting, or to learn what Stafford covers healthcare science for your representatives, or maybe it is to listen to a podcast and learn about persuasive brevity and messaging. But perhaps in your next grant, there will be more time dedicated to investments to expand this type of engagement. And so my final thoughts, 2 thoughts to share today are: one, to set reasonable expectations for the powers of policy and advocacy to change systems. In my experience, policy and advocacy often follow society, and there are many, many ways. All of the pro-equity policies that I've mentioned are in the wake of some pretty substantial societal shifts. And my second closing thought is to always be an advocate in community with others. So with that, I'd like to thank everyone again. I'll now pass this off to Dr. Ronit Rydberg to give us a sense for Fed's meaning in the wider food as medicine field.
Great. Thank you so much, Brent. Good afternoon, everybody. Thanks for sticking with us for all of this really important information. My name is Ronit Rydberg. I am a research assistant professor at the Food as Medicine Institute at the Friedman School at Tufts. And I'm really excited to share with you 2 specific ways that I'm personally looking forward to using the Fed workbook. So for context, next slide, please. For context, the FIMI is a collaborative across Tufts University. Our aim is to advance food as medicine research, training, patient care, and community and policy engagement. We have almost 10 ongoing research studies of produce prescription programs right now. So this workbook is extremely relevant to our efforts and also to those of our colleagues all across the country. Next slide. I consider the Fed Community Workbook like a huge menu that we can approach incrementally. So this is not an all or nothing proposition. Instead, this is an accessible framework to guide our thinking collectively 1 page at a time. And the first page that I'd recommend is page 11, where you'll find the table that Ben highlighted and that others have mentioned, which compares the approach to produce prescription programs designed with and without Fed principles in mind. So one of the examples he shared was that outside of Fed, a program may be designed with the assumption that patients or participants have deficits of knowledge and decision-making that the program will address. So instead, what happens if we consider that patients have assets of wisdom, culture, and community as participants in these programs? How might this change your approach to designing a program or to evaluating it? Focusing on this page and this chart was a really meaningful and direct way for me to first just get a better understanding of what fidelity, equity, and dignity can look like in a produce prescription program. The second way I'm excited to use this workbook may be a surprise to its developers, but I see a built-in supercharged resource for qualitative research. So we need more stories, right? We need stories to support a deeper understanding of individuals' lived experiences, especially as participants of produce prescription programs. How are people using their benefits? What helps them feel respected as program participants? Does the program actually fit their needs? How could the program be more culturally appropriate or responsive to their lives? At the heart of the workbook, so as described so beautifully by others today, are these checklists from multiple program touchpoints. And if you look at these checklists from a qualitative research angle, they can actually be an asset by guiding interview questions or focus group topics to gain new information from participants, which has a potential to add both depth and specificity to this more generalized approach we often take of looking for barriers and facilitators.
So if a checklist item, for example, says the program participants and program operator partner together on the evaluation design, you might consider asking in a focus group, did you as participants have any opportunity to help design the program? If not, how would you have liked to have been involved? And as an added bonus, you can use these checklists to generate qualitative research questions, even if your program is already underway, or if you haven't used the checklist to design your program. So these are just two examples, two ways of many that I can imagine using this workbook in the food as medicine field. And I invite you all to consider which first steps or which first considerations you might want to take to begin to transform the produce prescription landscape with attention to fidelity, equity, and dignity in your implementation or evaluation efforts. So I'm really looking forward to your questions and to our discussion, and I will turn it now back to Maham.
Thank you so much, Roni. And thank you to all of our presenters today. You all have been my colleagues, many of you since 2021 and others along the way. And truly feeling grateful to finally have this output to our peers nationally. For all of you in the audience, I'm sure by now there's been information thrown at you and you're wondering, okay, what's next? Or what do I do with these tools? This is a little bit of how you all can get involved. One, we'd love it if you downloaded the Fed Community Workbook and our supporting resources, like some of our qualitative research yourself by going to fed.wholesomewave.org and sharing what you find with your field peers. Dig through the materials and share them with colleagues, send them to folks. We'd also love it if you reached out directly to us and let us know what you thought of this webinar. If you'd like a direct workshop, either conducted virtually or in person, you can reach us at fed@wholesomewave.org. And if you'd also be interested in contributing to a second edition of the Fed Community Workbook, as Maria Elena previously mentioned, it is an iterative document. We expect it to adapt over the years to be influenced by multiple produce prescription programs on the ground. And we hope to hear from you if you're interested in collaborating. I'll now move over to Q&A and open it up to all of you. I appreciate the folks who have been telling us a little bit about their thoughts in the chats, some of, even if they aren't questions, just reflections, and folks have left some questions directly in the Q&A button. I'm going to read directly from there and direct it to a specific speaker if that was specified, or open it up to the floor if it wasn't. So our first question I see here, thank you all for the great info so far. Love to hear about the tools that are in process, the co-design manual, the equity manual, etc. When do you anticipate these tools will be available? And this is a Kathleen and Elizabeth question.
Great, thanks for the question. So the co-design manual we expect to be available this summer. We are working on that, which will include some of the pieces I mentioned, as well as kind of a case study related to co-design. The equity manual is something we're developing as we go. We're not funded for the equity manual as of right now. We're looking to get some funding for Summit to really produce some of these tools. So that's very much in the nascent stage. And related to the tool I had mentioned, the scale development, we've been working on that and looking to hopefully validate it moving forward. So that would be with a very large scale validation, but that's hopefully our next step. So those are a little further down the pike. That being said, we will likely be looking for partners for that validation study. So for those of you who are on the ground, very much partnering with us on developing these manuals and really trying them out, adapting the materials is something that we would welcome. So our action lab currently meets on a weekly basis. So it's very much action oriented, where we provide feedback as we're using the tools on the ground. That is something we're also looking to expand. So hopefully we'll have the opportunity to do that with some funding that we're also seeking. I hope that helps.
Thank you, Kathleen.
Sure.
Another question for Hispanic Health Council, Andrea. This is a great program for moms in Hartford. Is there a plan for rolling this out across the state and to different at-risk populations?
So yeah, my understanding is that once we've completed the Food for Mom study, we can use the findings to inform policy. Kathleen can also help me answer this question, but I believe that is the end goal, to be able to then expand it to nationwide and to different at-risk populations. Yes.
Exactly, Andrea. So also just in the short term, some of the expansion that we're really looking into is expanding to also do the program, extend this program to cover the first year of life, and really seeing how that rolls out and doing that in a way for outcomes for both the mom, the child, as well as the larger family unit. And then also doing this in other sites and for other populations. So we're right now actually engaging in those conversations to do just that.
Good to know. Thank you, Kathleen. Next question is directed at any panelists. Are there any things you wish you wish had ended up differently? Any lessons learned? You expected X, but you ended up with Y. I'm sure we all feel we're in process. Yeah, Kathleen, feel free to jump in, or anyone else.
Jump in here. So I think sometimes in the co-design, we're unable to actually respond to everything that the community would like or that would work for them. And I think that's a really challenging situation to be in, where you want to provide, say, the transaction at a site that the community wants that transaction. Things like that. So I think those things do come up, and to be prepared preparing the community in advance, that we will be trying to create the program together, but we may come into some of these systems issues that we're also trying to address, right? So through the Fed framework, we're trying to address these systems issues as well, but some are going to take a little time. So ensuring that we have our eye on that and that we're working on kind of these systems issues at the same time that we're able to move forward with the program itself. So I think those are the kind of those challenging moments, but also highlight the importance of the systems change.
Thank you, Kathleen. If any other panelists want to add to that, you expected X and got Y scenarios. Okay.
I guess
I think Andrea's
just
gonna jump in.
Yeah.
I'll just jump in really quickly. Well, it did happen often when implementing the Food for Moms, the pilot group, but I think that's why the workbook was so helpful, because it helped inform, like, okay, how can we do things differently, which is what I showed you with some of the criteria that just showed us, like, oh, we can innovate more on this point and whatnot. So there were I can come up with different examples like the one I presented, that we expected things to be this way and to be fulfilling, but then in practice, right, it didn't. And then now we're innovating.
Yeah. I'll add one as well. I wish our core authoring team of the Fed Community Workbook had included a program operator from a PRX program. We consulted many that in a sort of long process of convening a national advisory group to review the materials we were developing for the Fed Community Workbook. Program practitioners like yourselves in the audience got to read our materials and give feedback and edit, and we were drawing from direct experience being technical assistants to many programs. But I wish we co-authored with a program like any of y'all's. So second edition, keep your eyes out and ears perked if that's of interest to you. Next question we have, co-creation of programs is a wonderful idea. Any of the panelists, are there any areas or watch-outs where the reality of your experience in the field fell short of the ideal? Maybe, Andrea, that touches a little bit on what you were describing.
I think I also was trying to address that one too.
Go for it.
Yeah.
Okay, I'll say one that I think Kathleen basically touched also, and well, with the co-design phase, right, a lot of participants wanted different stores in Connecticut or more specific stores, for example, that were stores that they would more often go to buy their fruits and vegetables that had more of that, of those fruits and vegetables that they're more used to using while cooking, right? And unfortunately, the way it's set up right now and the way that it works with our redemption options, that wasn't a possibility. So that's one of those experiences that felt short or a little bit, but like Kathleen mentioned, also it is something that we're looking forward to seeing if it can expand with system changes. And
I think also in our partnership, now we're partnering with many PRX programs, say within Connecticut, that just even our collective voices being heard will be really important in moving this forward and addressing some of these, less than ideal situations. So that's our hope also, is then to be those advocates that Brent is calling for.
Thank you. Another question we have here: how can BIPOC farmers become eligible to participate in the PRX program? On the other hand, how can program participants find BIPOC farmers who are eligible to participate in the PRX program? Yes, this is a great question. Anyone want to take it? It hasn't, no specific directive. Perhaps Maria Elena?
Yeah, I can contribute that. So I'm speaking not as a program operator. I have never run a produce prescription program, but in my role in a number of these different research projects, I have spoken with program operators across the country, documented their experiences. That's what I'm drawing from, not from lived experience. And I actually feel like there's probably many, many program operators on the line who could answer this better than I can. So please feel free to also, if any of you see any of these questions and want to respond from your experience in the chat, please do. There is a lot to share, I'm sure, from all of your wisdom. I have spoken with a number of program operators that specifically have been committed to working with BIPOC farmers. The question about eligibility, I think it's really about partnership building. It's really about programs that are running a produce prescription program, finding out who are the BIPOC-led farms in their community, finding out, building relationships with those farmers. I think these are things that take time, they take dedication. It's not always, as many of us know, and running different programs, it's not always easy as kind of identifying someone and then immediately there's a pathway that makes sense to support each other. You potentially, understand, like come across a potential BIPOC farmer, and over different seasons of time, you can build again that pathway to be integrated into a produce prescription program. I know that some programs have, again, as we mentioned earlier, approached their program operations in all sorts of different innovations. Some of them, the voucher in particular is redeemable at a farmer's market. So participants go to a farmer's market, which may or may not have BIPOC farmers, of course, depending on the community, but there's that direct connection. Or some programs will partner with a BIPOC farmer to do a CSA model, community supported agriculture, where the farm can assemble produce into boxes, and then it's a more direct kind of working with one farmer in that way. So I think there's a lot of different ways to structure that, really based on the individual community. And again, if there's any folks in the room that would like to add to that in the chat, please go ahead and do so.
Thank you, Maria.
Yeah.
Oh yeah, go ahead.
I'd add an observation. I agree that there's probably plenty of people on the line who will have great answers here, and I hope they jump into the chat. But there's ultimately a decision maker for what type of produce prescription they want to make available, and ultimately we like the patient to be that decision maker. So the patient, we want to work towards a day where the patient want to get their food from. But I think the key thing to get comfortable with is whether you're talking to a funder, like in the philanthropy space, or a health insurance plan, or a hospital system, or a Medicaid director, being ready to describe why the product coming from a BIPOC farm is better. for the patient and better for the system. And getting more comfortable with that using the Fed principles, because there's a lot here that can help you get to those answers. Being ready to talk about that will be best, because I think my observations in watching hundreds of these programs start in lots of different ways is that the common first step is to go to what applies to most. And for most people, that is a knee-jerk reaction to a large grocery chain or something like that. And so it's about like finding who isn't served by that model and making that person visible to the decision maker, I think is key.
Thank you, Brent, for that addition. And so appreciative to some folks who have responded themselves and added additional resources in the chat. I'm going to move on to the next question, just in the interest of time. We have until 3:30, you all, so we have some spaciousness, and I really appreciate how many questions have come in. If we don't get to your question live, we will save them and find a way to answer them directly to you over email. If you haven't included your name, you can email us directly at fed@wholesomewave.org, and we'll make sure to answer. But from Julia Koprak, can Ben and/or Maria Elena share a few additional examples of lessons learned or feedback from BIPOC leaders, perhaps as it relates to intention versus impact in program design, and how to balance these values with the standard desire to scale quickly?
I can start, and then perhaps Mary Elena, feel free to add. One of the things in the presentation we talked about was the field scan and some of the findings that came out of the field scan, specifically as it relates to BIPOC organizations and program operators. And so as a result of some of those findings, one of the things that we decided to do in year 2 of the funding from Walmart is to actually do the work of convening a group of BIPOC program operators who'd be interested in helping to develop a kind of community of power and practice. And so we're actually at the very sort of beginning of those processes, of that process. And we have a group of 4 organizations who are part of that, and a couple of other organizations that will be engaging as well. But I think in many ways, a lot of that work in terms of building a community of practice and power will help us to address some of these issues. One of the things I'll say, interestingly enough, with the group now, with the cohort, is we have had some opportunities for them to be in conversation, for instance, with Yale, to talk about the respect metric and to provide some feedback in the ongoing development of that respect metric that both Kathleen and Elizabeth talked about. But we anticipate, as we continue this journey, that we're going to have a lot more information and likely a more sort of complete answer to the question you pose about the challenges and how to balance these issues and the issue of scaling and all of those things. One of my hopes would be that we would be able to begin to answer some of those questions and raise some new ones as part of the learning journey with the BIPOC program operators and organizations. But Mary Elaine, I don't know if there was anything else you wanted to also add there.
Yeah, thanks, Ben. That was super helpful. And I really appreciate this question. And I think the topic about scaling, I mean, this is a topic that, as many of you, I'm sure, think about, work through. I mean, I've spoken with dozens of program operators about this very question. You know, what's the size of the community that you're currently serving? How are you looking to grow? What's the, the sustainability of your program and scaling? And I actually want to push back just a tad and calling it the standard desire to scale quickly, because I think for some programs, it's absolutely the goal of, okay, we've got this model, it works. Let's see, like, how can we double, triple the numbers, get more and that's an absolutely legitimate way to think about program expansion and program goals. I think I've also talked to a lot of programs that, recognize in their community, they're serving a certain number of individuals or families. and through their programming, and they do want that to grow, but there is an understanding that it has to be at a little slower, more organic pace in order to really apply some of these equity principles. So many of us have heard the phrase moving at the speed of trust. It's very related to that in the sense that when you read through the workbook and you see some of the examples of the criteria, some of these, again, these are not things that from one day to the next, it's very easy to just implement. They're going to take time. They're going to take building relationships. And sometimes you build relationships and then there's a change in leadership and you have to rebuild relationships all over again, or your funding stream runs out and you have to shift your focus. So I just want to mention that in the sense that some programs may have different goals or different realities around the pace at which that they can scale. And as we mentioned before, the criteria in the workbook are really aspirational. There's no program out there that, you know, is checking every single box necessarily. And it's also iterative. As Andrea mentioned, you know, it was kind of a retroactive, you know, your program is already up and running, then you take a look at the criteria, you're judging, okay, where do we land here and where are we trying to head? And that is an iterative process. And in the topic of scaling, is something that takes time. So I think, I don't know, that's just what came to my mind in reading that question and thinking about some of these pieces in the workbook are going to be over the course of seasons, over the course of years as programs grow and develop. And some aspects might be quicker and more rapid to implement, and some are just going to take time in that complex partnership development.
Thank you both. I think we have time for another few questions, maybe two more. What about adding other foods beyond produce to food prescription programs? I imagine this can be answered by anyone, and I'll just answer quickly. Yes, we hope that FED applies to programming beyond produce prescriptions. As of now, produce prescription is explicitly for produce, fresh produce. But for other food as medicine programming, FED can absolutely be applied. If anybody else would add anything to that, feel free to come off mute.
I wanted to just say there was a question I think I saw in the chat that was, you know, can the FED principle be applied to medically tailored meal programs? And I think this is in relation to what you're sharing, Maham. I just want to share that, yes, absolutely. I think Ben shared at the beginning that the FED principle in general, we're using it right now through the lens of produce prescriptions. But the vision is that within the broader food as medicine tent of potential, you know, medically tailored meals, other types of interventions, that there is the opportunity to adapt the criteria towards those programs. They might, you know, they're going to look a little bit differently, but absolutely the spirit behind the FED principle is that within that broader food as medicine programming, it absolutely can be applicable, and even beyond food as medicine, even to just food systems transformation, food, you know, security, nutrition security. There are components of the FED workbook that can be adjusted to evaluate other types of programs. So that was the vision of kind of creating that it can be very applicable beyond just produce prescriptions.
Thank you, Elena. And yeah, perhaps public health intervention in general. I'm going to read a question that also was listed in the chat and not in the Q&A section from Diane Schoenberger. Many of us are grant funded and limited by how our grant was written. Have you tried to get the USDA to incorporate this concept in its RFA? I personally love this question, but if anyone is compelled to respond, feel free. Okay, I'll take it. Diane and everyone in the room, our aspiration is absolutely that USDA, NIFA, or grant writers who compile the grant opportunities at USDA for produce prescription programming get familiar with FED and incorporate some of these principles, especially the evaluation expectations, in partnering with Gretchen Swanson Center for Nutrition, and possibly allowing for a planning phase grant for particularly CBOs, community-based organizations, to build out partnerships and have the cash to sustain their capacity while building those partnerships. that is our hope. And those relationships are definitely in progress. Those are our colleagues as well. We work closely with them. And NIFA is also iterating each year on the GusNIF RFA. So we expect down the line, there will be some influence. And then I'll read a last question here from Hester Parker. Thanks for the great model for us all to use. I would like for our participants to have more agency in tracking their own results. But as the CBO that is operating the program, we're not allowed to have access to the patient's biometric data. I'm afraid that asking our partner clinics to initiate this change on their end to allow patients more accessibility might create more burdens to overstretched clinic staff. Do you have any suggestions in the materials for implementing FED without increasing the workload of clinic staff? Oof. Kathleen or Elizabeth, either one of you that have worked closer to clinic staff?
Well, we've had some support from dietitians in one of our projects, and that was a nice place for both nutrition ed as well as that kind of data feedback, health data feedback. So that was just one that was already in place. So we can think about that as we expand.
Thank you. Hester, just to share, the workbook itself does not offer those suggestions. And that is definitely something to consider down the line. There's these exemplified criteria without how-tos. And if you were filling out the workbook, you might mark that one as X, as like not feasible for your program to implement. But if it was an aspirational thing, you wanted to find a way around it, at least for now, the workflow we could create is trying to potentially consult with you on strategies based on the existing relationship you have with your clinic partners. So if you were interested, again, please do reach out at fed@wholesomewave.org. It's absolutely a conversation we want to have on what happens with these suggestions, these exemplified criteria that are not necessarily feasible right now to implement in your program. What's the next step for us, the Fed development team? And that draws us to a close. And luckily we got through just about all the questions. There's one left in there that's more of a comment. I'll add it to the chat. But I just want to thank everyone for joining us today and your attention. We're so grateful for that. Of course, this is a labor of love, but it has been created by many more people than just us presenters on this call. And we want to connect you all to them. We want to be connected to you all. So please scan this QR code or follow our steps, suggested steps over here to download the Fed Community Workbook and the supporting resources yourself. Stay in touch with us. You can find any of our direct email addresses online or reach out at fed@wholesomewave.org. And we will also have a follow-up email with the recording of this webinar and the slides for you. Have a good day, everyone. Happy Wednesday.